So next we're going to do, which I think will be an interesting one, the truth behind the efforts to squash COVID. And that is going to be really one that I've been looking forward to. And it's the COVID lab leak theory. And it's going to be moderated by our wonderful, I would say board advisor, but even better friend, Ambassador Dr. Deborah Birx, and it's going to be then a panel of Dr. Maan Fares, who is Chairman of Global Patient Services for Cleveland Clinic, and Dr. Hahn, who is CEO partner of Flagship Pioneering. So I've asked all of you to come up to the stage, and then we'll keep moving forward. But again, a wonderful first part of the morning, and it continues to move forward with this next panel. So thank you all very much, and please don't go away. I think this is going to be one that will keep us all in suspense.
So today we're going to be talking, it's really a great honor. I never thought in my life that I would be sitting next to Dr. Birx, who led, along with Dr. Fauci, our national effort with fighting the pandemic and guiding us through the pandemic back in 2020. In fact, I will tell you another fact about myself. I was the first doctor to have COVID at the Cleveland Clinic. So I was following Dr. Birx from my inpatient bed and watching with great attention everything she said, and Dr. Hahn. But before we dive, Dr. Birx, would you mind introducing yourself?
Oh, hi, I'm Debbie Birx. Really a pleasure to be here. Mostly because we're going to talk about why we have our perceptions and assumptions about things and why everybody hasn't moved to robotic surgery despite the better outcomes. And that's because as physicians, we don't like change. So we're going to talk about that today and how that leads to some missed opportunities, we'll put it that way. Steve?
Introduction?
Yes.
First of all, I am in fact recovering from that reputation.
In a good way, really impressive work, and congratulations for what you've done. It's remarkable. So Steve Hahn, I trained as an oncologist. I am not an infectious disease expert. I learned a lot from Dr. Birx during COVID, and was the 24th commissioner of the FDA during COVID, at least the beginning part of it. And now I'm a CEO partner of Flagship Pioneering and run a company called Harbinger Health, which is cancer-based.
Terrific. So we have, as I said, about 40 minutes, and I want to talk about all the misconceptions that really, and the misinformation that sort of saturated the media and everything in the early phase of the pandemic. And in fact, some of it continues to exist today. And also we know that physicians, even when they're scientists, even when they're driven by data, they start with concept, and those concepts are based on their biases and the way they think. And unfortunately, many times they continue to follow this bias, and they are not even persuaded with their own data. And that's where hopefully artificial intelligence will come to tell us something. So, Dr. Birx, can you explain to us, take us back into the early days of the pandemic. How did you come to realize the pandemic was here? And tell us a little bit about the misinformation prior to you going to the White House.
So I came out of the HIV/AIDS field, and so quickly we have forgotten that. We have forgotten that it was all misinformation. Remember that? Remember the cures? Remember the promises of cures before we had a cure? Remember the mosquitoes? Remember the kissing? So when we have a pandemic, there's always misinformation. And it was so interesting to me coming back to the White House and have people in the media say, isn't it shocking that there's misinformation? And I'm like, every pandemic has misinformation. But we don't learn from that. And so if we had learned from the HIV situation, we would have known immediately that there was going to be misinformation and started with that as a premise and reminded people about HIV. The other thing, though, that HIV gave us was decades of investment in trying to understand how HIV attacks the body. And it was through that understanding that we finally figured out how T cells work. It may seem like just common knowledge now, but we didn't know all of that about suppressor and killer and cytotoxic and helper. We didn't understand all invested in basic immunology. And it's that basic immunology that grew out of our last pandemic, the HIV pandemic, that will teach us and taught us about cancer therapy and how to really activate your own cells to target your cancer through activating your T cells. So good things can come out of pandemics if you invest in them right. And so this pandemic, I was working in Africa, getting Africa ready for the pandemic because I was working on HIV, TB, and malaria. And we were getting ready. We met with all the ministers of health and all of the diplomats in January. I said in January, this is going to be bad. We have to get ready. We have to test. We have to activate. And what another great thing is, those HIV viral load machines, exactly the same machines that we use for diagnosis of COVID. And so that investment that we all made around the globe, and I know many of you belong to philanthropic organizations that invested in HIV, TB, and malaria around the globe, it's those very testing platforms that became the platforms for the COVID. So the Cepheid platform, the Abbott platform, the Roche platform, all of those platforms became critical. So, misperceptions. I could not get our CDC or the WHO to believe in asymptomatic spread. If you remember, even into June and July, they were saying less than 5% of the cases. And I'm like, it's not possible because we have everybody sick that's of a certain age, and we're pretending that everybody that's not of that certain age, that we don't see and is not sick, never got infected. And infectious disease don't work like that. So if you're only seeing sick people, they got sick from someone. Look around you. No, just kidding. Just kidding. The wastewater is finally going down, and that's why I can be without my mask, although it's always close by. So I could not get them to see that there was asymptomatic spread. Now there was that ship that taught me this in February. One of the princesses in Japan. People got infected. They were only testing the symptomatic passengers. Now the crew, average age 25. Never tested a crew member. Now where do you think those people who were locked in their cabins got infected from? The asymptomatic crew. So it was clear to me that there was huge asymptomatic spread, that people under 30 most likely did not have symptoms. And that the only way we were going to see this virus is through testing. And I just want to go with, because I know we're going to switch to Steve, who was brilliant on this whole piece. He was sitting beside me at that table in the White House day after day. But in addition to the asymptomatic spread, the other thing that took until 2 months ago, July of 2025, the WHO finally recognized that viruses can spread through the air. Unbelievable! Viruses have been spreading through the air preferentially for decades. It took COVID for people to finally realize that whole droplets, spitting, sneezing, coughing theory. No, it's just breathing. Just breathing. Just breathing spreads viruses. Those asymptomatic people breathing are spreading the viruses. The people that are sneezing probably don't have COVID or flu. I don't know. But I'm just saying, you're more likely to be exposed to an asymptomatic person that is breathing in your space where the viral particles can remain suspended for 4 to 6 hours. 4 to 6 hours. So when you go into that bathroom, ladies, and you're like, oh, I can take off my mask. No one's in here. Someone was in there before. And so all of our air is contaminated. Why is this important? Because we can work on technologies to fix it. Once we know that there's a problem, we can fix it. But it took 4 years. We cannot waste 4 years to fix what we need to fix. So that when H5N1 gets broader, that we're afraid again to go into inside spaces and we start closing things again. I mean, we've had 4 years to fix this. So I just, it wasn't just the Lavley theory, and we will get to that. But I just wanted to also cover these really important assumptions that physicians make based on what they have seen. So it was comforting to people to think they could see through flu through symptoms. I'll leave you with one last thing because I know I have too much time and you're going to get to Steve. We made the same mistake with H5N1 in the dairy workers. We only tested people who had symptoms. So they found 5 cases. And then finally someone had the brilliant idea to go in and test all the dairy workers because they were pretty young. And they found 15% of them had been infected. No one had been infected from that farm. 15%. So that means we're missing. So instead of 5, there was 50, maybe 500 cases. So it's these kinds of scientific blinders that we put on to comfort ourselves. But the fact that it's this year, this is 2024, and we're tracking H5N1 not through testing, but through symptoms, tells me that we really are not making the progress we need to make. It's just like if everybody in Norwich who just presented and just kept doing open heart surgeries, cracking people's sternums when there's other options. It just is shocking to me how long it takes us to make these changes. Okay, go ahead, Fares.
This was, she's passionate. We know that, right, from before and from now. But I'm part politician. And I'm not going to let you get away without telling us a little bit about the politics at the time. This is an era of social media. Social media played a role in misinformation, both at the public level and at the regulator or the policy-making level. And there were misinformation coming from both sides. So in other words, people were told, get on an airplane, you have to wear a mask, but then you can take it off if you want to eat, as if the virus allows you to eat. So take us back into the room when those decisions were being made, and the scientist in you, how did you feel? What were your thoughts? And I'm going to not also get back to you when we talk about the vaccine and how we promoted the vaccine to be.
Well, Steve and I both talked to this issue. I mean,
Feel free to both, of course.
I'm not shy. I speak my mind. I speak my mind in that room, and I spoke my mind in the Oval Office. All you can do is keep emphasizing the facts. But when you have an agency, and I'm just going to be frank, but everything I was saying kept getting undermined. And so when you get undermined by a federal agency, it allows an administration to use that. So they would come back to me and say, because in the 15 days to slow the spread and the 30 days to slow the spread, I'll just give you a quick example. I was adamant that it had to be, if you're going to gather, it had to be under 10. And CDC writes 50. Well, 50. I mean, you might as well be having a party. I mean, 50. I mean, because if you say 50, next thing it is 100. So I was like, no, it has to be 10. So I write 10 into everything. 10 goes all the way up. I don't know how far it went, maybe to the president. And I get a note back that says, well, CDC just put out their recommendations and it says 50. So neither of you do all what you're doing because you can't come to consensus. So that opens the door to people being able to say and do anything. Because if you can't get your public health agency to recognize aerosolized and asymptomatic spread and you shouldn't have gatherings more than 10, then it gives everybody the green light to disagree about everything. Then they can say, well, this is all perception. It's not data-driven. And that really became the story of our lives throughout this.
Yeah, I went to Washington not even close to being a politician. I was an academic for 30+ years, and it was very eye-opening because, unlike doctors who do the great work you do, where you don't care if you hate the person across the table from you, you just got to take care of that patient. That is not true in Washington, D.C., or maybe politics anywhere. And so I was struck by how that component of Washington, D.C. affected response. And I think we did see it on multiple sides, and there shouldn't have been sides at that time. So just a couple things. One is, I think Deb's comment about the CDC is very accurate. The CDC is basically an academic organization, and has been. Maybe that's different now, with all the pluses and minuses of an academic organization. And any of us who've been in academic medicine know that the suggestion that there is a bias in an academic institution is laughable. And in fact, that was what formed the resistance to much of what Deb was trying to say. We saw that from organized medicine, we saw it from the CDC, and it really did hurt us. And I'm not saying everything that was said was perfect. What I'm saying is there wasn't a dialogue about it that there should have been, because that's what you would do to take care of a patient, have a dialogue and exchange views. The other part of this that I think is really important, Deb and I know you and I talked about it. I remember being right outside the Situation Room. Deb slammed a piece of paper down in front of me to educate me about infectious disease. There's a big red hot spot in Lombardy in northern Italy. It says, it's already here. And I'm like, it's February, it's not already here. She goes, oh, it's already here. And sure enough, 2 weeks later, it was here. But I think one of the keys of that is this had started months ahead of time. And that information about that disease and how it spread, and potentially folks even knew that asymptomatic spread under the age of 35 was a thing, we didn't know that. And that seriously impaired our move forward. So I learned a huge lesson about transparency and exchange of data with public health agencies around the world. This was not just a US issue, it was a worldwide issue. And that was a real problem.
I couldn't agree more. I mean, and now we're seeing the mpox pandemic that is about to spread around the globe, and it seems like we haven't learned anything, and maybe just a matter of time that some of us will have to face that reality. Steve, I want to ask you a little bit, on the bright side, it was very rapid development of vaccine and rapid development of remdesivir at the time. So as an oncologist, as a scientist, can you take us a little bit and shed light? Because it almost seemed like it was incomprehensible that we, within months, literally not years, months, we had a product on the market, and we started to distribute.
Identification of the viral sequence of COVID published on January 10th or 11th, I forget the exact date, it's forever, in 2020. And first emergency use authorization on December 11th, so 11 months from really identification of what we were up against genetically, and then the development of a vaccine. Well, I'll start by saying my baseline knowledge of vaccines and vaccine technology came from a very quick and intense lesson about vaccines from Deborah Birx, so that's where it all starts, to be honest with you. But what we did at the agency, at the FDA, was we knew that we were going to be faced with issues, convalescent plasma, hydroxychloroquine, et cetera, in terms of quick therapies off the shelf that we could get. And we wanted to facilitate that, and we very quickly developed an emergency response team that had multiple facets, including diagnostics, respiratory meters, et cetera, but more importantly, vaccines. And so we started planning really in February of 2020 about how we would approach that. And I remember one meeting we had in the Situation Room with Deb where we went through the potential matrices of the different vaccines. And one point that I want to make is that we are very fortunate in this country and around the world to have the private sector we have. Because at that meeting we presented, 50 options from companies around the world. This is the vaccine we'd like to develop. In the absence of people taking risks to develop, we wouldn't have had the vaccines that we had. So really just major kudos. So we had these options in front of us, and we didn't know, obviously, a lot of information about which vaccine would work the best. And so we kind of opened it up to almost everybody in different categories of the vaccines. Some were funded by Operation Warp Speed, some were not. But we encouraged, obviously, the development of all of these verticals of the different vaccines so that we could have multiple shots on goal. We outlined very clearly what the criteria were going to be for preclinical and then flip to clinical work. And then, obviously, the design of the trials was laid out ahead of time. And one of the lessons learned for the agency, I think, which, like Deb said, that I'm a little disappointed is the drift back and doing things the old way. is that there was real transparency and back and forth with companies. So these were real-time reviews. So normally what happens is you do your preclinical work, you do it in animals, you send it to the agency has 30 days to get back to you, sometimes it's longer. Then you say, fix this, then you come back, you can see why it takes years to get a vaccine developed. We said, send the data to us every week. We'll take a look at it, and we will respond to you in real time. So that when you finally submit the preclinical data, it's 24 hours to say, yeah, go to your phase 1 trial. And by the way, we're letting you know, go to your phase 1 trial even earlier so you can get things ready for that. So in March of 2020 was the first patient dose of the Moderna vaccine. So think about that. You know, identification of the virus in January of 2020 and your first phase 1 of an mRNA vaccine, March. I mean, that is more than light speed, that's for sure. And then we had to develop guidelines about what we wanted to see in the phase 2 and phase 3 studies, and so we did that. And we published that, and of course we got a lot of feedback. And one of the interesting things about the FDA in Washington is that it's considered a bad thing to have too much interaction with industry. I mean, that's actually considered a bad thing. And of course, we threw the book out in the emergency use authorization time because we had to. And the only thing I'd say is it's not like the FDA is a pushover, but more interaction was better and speeded development. And it doesn't mean it would be an automatic approval, it just meant let's have the dialogue. So that continued throughout, and as you know, it was July of 2020 when the first patient was dosed in the randomized trials, and then it went from there. I think the other big lesson that I just wanted to mention is the incredible tragedy of healthcare disparities around the globe, and of course we face them in the United States. And not paying attention as much as I think we should have to the diversity of our clinical trials slowed us down by maybe a month or two in terms of getting this vaccine out. And that's not good. That's not right. And we have to be much, much better, both from an ethical point of view, but also more importantly, a scientific point of view, because that diversity is key.
That's outstanding, and it sounds like now with the FDA we're going back to our old way.
There's no dialogue anymore. Try writing as a company now that I'm a CEO. Yeah, they're like, we don't do meetings anymore.
Zoom meeting. So sticking with the topic of vaccines, it was an mRNA vaccine, and now we're talking about protein vaccines, and now we'll want to hear your thoughts about the difference between the two. But did we, for years, we've been trying to develop a vaccine for HIV, and we could not come up with a vaccine that provided full immunity. This, as a cardiologist, I don't know enough about the vaccine, but did we oversell that this mRNA vaccine will give 100% immunity, and rather it will give decreased virulence of the virus, and maybe the spread will be less, and the disease will be less intense? What have we learned over the last 3 years? And maybe Deb, can you start with Steve, and I want to hear also Deb's thoughts about the vaccine and where we're going with the protein vaccine and the combination with the flu right now. So Steve.
Yeah, you bet. I'll just, again, oncologist, not an infectious disease person, but just, so a couple of comments about that vaccine and kind of what we learned to your point. One is speaking the truth about what a vaccine can and cannot do is really important. So information that was relayed to common folk around the world that this would prevent the spread and prevent you from getting sick, as opposed to what we learned in the clinical trials, which was it's going to keep you out of the hospital and not die. That's a really good outcome. That was the short-term endpoint we wanted. And so when you don't actually tell the truth about what something can do, you lose trust. And that's a huge part of the component here, I think, of what we saw. I don't know if anyone saw the report today in the news about the mRNA vaccines and immunotherapy response to cancer treatment. Really, really impressive. So even to this point, 4 years later, we're learning a lot. And the analysis basically showed an aggregation of data that having received the mRNA vaccine and presumably the immune response could enhance one's response to immunotherapy for cancer. Fascinating. There's something to learn there that could really help us. But the last point I'll make is $12 billion, from Operation Warp Speed. I'm going to argue it's the best $12 billion U.S. government spent in the last 5 years, maybe 100 years, I don't know. Really important because it facilitated it. But what we ended up doing with 2 mRNA vaccines is have the biggest and most impactful real-world evidence post-marketing study of a medical product. And everyone here knows that every medical product is not going to work as well in the real world, and it's going to have side effects that we're unexpected. That's true of a vaccine, it's true of, cancer therapies, etc. But at the end of the day, collecting data on some subset of 12 billion people who receive COVID vaccines, really valuable. Shame on us for not learning about that, and I think we will learn a ton about what that meant. And I think it will help us in other, pandemics and other infectious disease-related situations.
He's so diplomatic.
Any listeners learning?
Being diplomatic got me in trouble.
So, where did we get off track with these vaccines? Because we were on track. We were on track up and through November of 2020. On track of doing a clinical trial where we didn't test people. We only tested people who were symptomatic. So if you were in the clinical trial for testing the vaccine and you got asymptomatic disease, we didn't know it. Because the only thing that we were looking at, which I think was the right thing, is prevention of hospitalization and death. Okay, so how did we get off track? We got off track at that very first meeting of the vaccine, what are they called? Advisory Committee? The Vaccine Advisory Committee, which decided, even in the face of that data, that we were going to immunize 25-year-old nurses rather than 90-year-old people in nursing homes first. Now, if you're trying to make a vaccine that saves people's lives that are older, who gets the vaccine first? The people who are dying. You can see the surge coming. I mean, the one thing that I learned is, data and real-time data is extraordinary. So we had every hospital reporting every night. Everybody said the hospitals wouldn't do it. 6,000 hospitals did it. We had 96% compliance. It was extraordinary. Private sector, hospitals, everybody helping us. So we could see the fall surge coming. I can see that it's going to kill between 200 and 250 individuals between January, February, and March. And I say, and I write Steve, and say, go to those companies, get compassionate use because we know it's safe. Let's get that vaccine in everybody over 85 right now so that they're protected before the surge. Oh, no. We're not going to do that. So then I go back to the CDC and think, okay, they're going to help me. I write them and say, let's get this vaccine in every nursing home before Christmas and save these individual lives. And what did they do? They put out the vaccine like they put out any other vaccine. It's going to the healthcare providers. Now, where did that vaccine sit? It sat in every refrigerator in every single hospital because there were a lot of 20-somethings because the study didn't include enough pregnant women who were smart enough to say, I don't really want this yet until you prove to me that it's okay in childbearing age. And besides, I'm not going to get sick. So when you start using a vaccine as a preventing transmission and infection, and that's your first thing out of the block, and you know your vaccine can't do that, that becomes confusing to the American people. And then we said, oh, you don't need to wear a mask anymore. And I can tell you people died because of that. Because people got vaccinated, they went into celebrations with their family and they infected their elderly family members, and they did die. Because the vaccine isn't 100% protective, even for the people for disease and death. And we're losing about 750 to 1,000 people a week. You wouldn't know it, because we have a little problem with age discrimination in this country. So once it stopped killing 40 and 50-year-olds, we sort of decided it wasn't that important anymore. Now we're saying you don't need to get a vaccine until fall. Well, what about the people who live in the South? And that's their primary surges in the summer. So we just told all the people in the South, it doesn't matter. You're not really part of the United States. Don't worry. We're worried about New York, Boston. We're not going to worry about Jacksonville and Jackson, Mississippi. We can't be like that. Either we're going to look at the data and a summer surge and there's a winter surge. And so if you're over 65, you should probably get vaccinated in May to protect you against the summer surge, and you get vaccinated again in November to protect you against the winter surge. We're just coming down from our summer surge. So the winter surge is probably going to be a little late. Well, the American people are smart. And so when they see this and hear this, they get very confused and they start not trusting government. And when we say things like go to Walgreens and go to CVS and get your vaccine, and you live in West Texas and the closest Walgreens or CVS is 200 miles away and the only thing you have is a dollar store, again, it says to these people that the federal government doesn't understand how I live and doesn't understand the commitment I have to make to lose an entire day to go get a vaccine. So these are the things 4 years later that we're still having the consequences of. Because childhood vaccines, like primary infection, provides herd immunity because you're one and done. I'm not going to ask you to call out, but there are people in this room, I'm sure, that had measles. And you remember if you had it once, you didn't get it again. That's why the MMR works so well. But we knew from the beginning of 2020, by about November of 2020, we could see the second surge, and we knew people were getting reinfected again. So we knew that nature only produced a 4 to 6 month protection against infection, and that's what the vaccines were going to do. I mean, we had the evidence base, but instead we sort of made implications about herd immunity and protection about infection, and we didn't give it to the elderly first. And so that became very confusing to the American people, and now we're paying the consequences. That there are parents now asking me, what about childhood vaccines? Well, childhood vaccines work. They protect against infection, they provide herd immunity, you don't get sick. That COVID vaccines are not going to do that. We should have the second, third, and fourth generation vaccines by now that do produce more prolonged immunity, but we stopped working on it.
All right, there are a few things that I want to get to. Talk to us about your thoughts about the protein-based vaccine right now, that shift from the mRNA to protein and the combination with flu. What advice do you have for us?
Well, the protein vaccine includes more regions. And you could, in some cases, more is more, and more is better. Some of these are concerned regions that are shared. How many people got the smallpox vaccine? All right, now I know you were all born after 1976. We have some young ones in the audience. And that's why Mpox, in that first time it came to the United States, vaccinia is very cross-reactive and was very partially protective against monkeypox. And so fewer lesions, better recovery, you know, these help, these longer vaccines against whole regions work. And I'm encouraged that the protein vaccine may have more durability, but it hasn't really been studied.
That's great. But you took the thought out of my head about smallpox and the future. Do you see us reintroducing smallpox vaccine to prevent Mpox?
Well, they're using smallpox vaccine in sub-Saharan Africa right now. And the reason children are particularly susceptible, because obviously they stopped using smallpox vaccine in the 80s. And so there's a whole generation that has not seen the smallpox vaccine and therefore are very susceptible to monkeypox.
Here in the United States.
And in Africa.
But here in the United States, are you worried? Do you lose sleep at night that Mpox may be coming? I mean, COVID, we live with it, so we're...
It's a respiratory virus, it's in the air. This one you need very close contact. So and you have to have a lesion. So it's not as, I don't worry as much about Mpox as I do about H5N1.
That's great. Steve, do you want to talk to us a little bit about new therapy, non-vaccine based therapy for COVID and or for anything alike?
And then we should do lab leak.
And then we should do what?
everybody's here for lab leak, so we'll get to that.
Yeah, I mean, I think quickly, one, certainly monoclonal antibody therapy and prolonged duration of that therapy is an important component. And that trigger needs to be pulled sooner. So convalescent plasma is a great example of something that is very, very safe, thanks to the Mayo Clinic and other academic institutions for actually performing that real-world evidence study that allowed us to do that. But that's something that has to happen sooner. And if the technologies are available for developing a vaccine, they're there for monoclonal antibodies. And I do not think we did a very good job of pulling the trigger on that, because by the time we made our EUA decision, we were making decisions on the basis of phase 2 randomized trials that had a couple hundred people in it. And by the way, millions of people had gotten COVID, so it just didn't happen quickly enough. And obviously, Paxlovid is, I think, a good drug, and it's effective. I think the course is too short, but there needs to be a lot more research on these viral therapies as we move forward, because that's an old drug that got repurposed like remdesivir. And so the more we put into that now, I think the more they'll be available in the future.
That's great. So, Deb, to your point, lab leak. Can you tell us about the misinformation and how do we, to me it seems illogical that someone would leak a virus purposefully.
Oh, not purposely. So if you're developing a vaccine, one of the ways to do a vaccine is what we call whole killed, where you grow the virus in tissue culture, you kill it, and then you immunize people with it. It's the simplest way to get a vaccine quickly. And so if you're in China, I am sure people were working on whole killed and live attenuated COVID vaccines. And so to do that, you grow it in tissue culture. And there are things that happen in the lab by accident. I mean, in the lab very close to us, we had an individual who got HIV when a centrifuge rotor exploded. So, I mean, it happens. Stuff happens. Stuff happens. You drop that tissue culture piece on the floor, and then all of a sudden there's COVID everywhere. I mean, this kind of stuff happens. Rather than saying this could be plausible, it became a blue-red issue in the United States, which is shocking to me. I don't understand it, because without knowing, and we never will know, because we're not ever going to get those samples from China, but you should take it could have been either, and then protect the world against either. I mean, put in new precautions for respiratory viruses that you're growing in tissue cultures to low concentrations, like we do with all kinds of viruses. But we didn't, because if you address the potential that it could have been a lab leak, then you were on the red side, and then you didn't want to be, so it became, because there were a lot more blue academic institutions than red academic institutions, it became, of course, everything had to be wet market. But it ignored the fact that we don't know, we still don't know, but more critically, because we divided that way, we wasted 4 years in taking new laboratory precautions, which to my mind is the most important thing. Because let's be very clear, you don't build a 10,000-bed hospital in January if you didn't have human-to-human transmission of a virus. And so in January, people are telling us there's no human-to-human transmission, and they're building a 10,000-bed hospital. So there was lack of transparency there. So whatever happened, it happened in November. It didn't happen in December. It happened in October and November. We know how long it takes for these things to spread.
We have a minute left, but I'm going to go over time by a little bit. Can you tell us about the cooperation between governments? You mentioned to me in the past that there was tremendous cooperation. You mentioned Israel, you mentioned other places. Tell me a little bit more.
The world came to our help. I just want to be very frank. When I could see this virus moving, I contacted my colleagues that I knew that were all over Europe, and I said, can you send me your information? And they are overwhelmed. They're dealing, Italy, Spain, France are dealing with an overwhelming situation. But every night they took the time to write me, saying who's in the hospital and who's dying. So by March 10th, we knew to protect the elderly. So when I say elderly in a broad sense, it was, people over 65 or people under 65 with comorbidities, but we knew that from Europe. And then we knew about vaccine duration from Israel. And Israel did a terrific job in mapping infection rather than protection against disease. And so we knew that, just like with natural infection, it was going to only last 4 to 6 months at the maximum. So that all came from people sharing data, and there's still not an organized way for like-minded nations to share data in real time. I just happen to know people because I work globally, but there should be a standardized mechanism that allows like-minded countries to share sensitive data in real time. And of course, we had tremendous respect for that data. We didn't go out and show every piece of data that we got from our European colleagues.
I could spend all day with the two of you asking more questions, but I want to give the opportunity for 1 or 2 questions to the audience, if anybody has a burning question, because we're over time. Go ahead.
Last season, you suggested that
Paxlovid 10 days.
Yeah, you suggested that it should go longer, but I've forgotten what the time frame was. 14 days? 2 weeks?
10 days.
10 days.
Yeah, the standard course is 5, and people get rebound when they stop the meds. So, yeah, Deb's been talking about that for years.
Yes.
So now, there's a surge, is maybe coming back. What are your recommendations for the new vaccine that's out? Is there
Well,
a
depending where you are in the country and when you just got infected or exposed, I would wait a couple of months because the winter surge, now, okay, the flu surge is going to come before the COVID surge. So optimally, immunologically, I would get my flu shot the end of October to protect me for both A and B often is in February. So to maximize that potential, and then get my COVID shot 2 weeks before Thanksgiving, because I want coverage into January and February, which is more than likely when the winter surge will come.
But if you've been infected, you still have to wait for 2 months.
You should,
You know, I know there are a lot of questions, and that's...
but I'll be here all day, so
but,
just...
they're both here